All right, let's go and open up our 3D app. And today we're going to be talking about the Sartorius on this slide. The Sartorius, we more than likely will know that it's the longest muscle in the body, and it's a pretty big contributor for lower back pain. Also, or from pain on the kneecap area. As you see how it comes down and attaches on the medial aspect of that medial side of the tibial, near the tibial tuberosity. The client would have pain there. Might also check the Sartorius for that. But also you can see how it comes in medial and kind of deviates into the medial aspect, comes up and attaches on the anterior superior iliac spine. I'm just going to go ahead and isolate that so we can just really see that. There we go. So we could see that it could definitely do a dysfunction or an articulation, if you will, to that pelvic region. If this muscle were tight, it would definitely pull it into an anterior tip pelvic. A lot of students or professionals might get confused on rotations, which can be very confusing from a client standpoint. I made a very conscious attempt. See if we can see this here. But whenever I go to look at rotation of my femur, I'm going to scoot this out of the way. I hope I don't turn my green screen over. But if I'm looking at the Sartorius specifically today, make sure I can see it on the screen good. All right, we know that it's going to do flexion based off of line of pull, so it's going to bring the kneecap out, and it's also going to perform lateral rotation based off where it attaches on the kneecap or that medial aspect of the tibial tuberosity. So if I get confused over which rotation it is with my thumb in this aspect, you can think about the Sartorius would also either cross your leg if you were to put your shoe on, or to do the number 4, it would come out like this right here. So I can tell my thumb is now pointing into lateral rotation as I do that action. If I were doing something that might be medial rotation, or I get confused with a client on the table, I can use this technique in my mind to see what type of rotation is happening, because it can get reversed in our mind if our client's in the prone position on the table. I hope that kind of clarifies why it might do lateral rotation. Most students think it may be medial rotation. They get confused when they start to learn the anatomy aspect of the musculature, or the A&P. All right, so once again, ASIS is the origin, which is going to be primarily more stable, less mobile, but there are instances where that pelvic region can do an anterior tip pelvic, a high hip posterior tip pelvic, and we'll get into that a little bit later in this lesson and in the lab. All right, thank you.